our second speaker, she had her post-residency fellowship at the National Kidney and Transplant Institute, her residency in pediatrics at the Our Lady of Lourdes Hospital. She had her Doctor of Medicine at the University of the East Ramon Magsaysay Memorial Medical Center, and she had her BS Nutrition degree at the University of the Philippines. Her current position and hospital affiliation, she's a diplomate of the Philippine Pediatric Society, a diplomate of the Pediatric Nephrology Society of the Philippines, and her hospital affiliations are San Pablo College Medical Center, Community General Hospital, San Pablo Doctors Hospital, Global Care Medical Center of Bay. To talk about why is P. Brown, a lecture on glomerulonephritis in children, let us welcome with our another round of virtual applause for Dr. Michele Machado-Lim. Doctor, you may proceed.
Okay, thank you. Sorry, there was a technical problem. Good evening, everyone. I am Dr. Michele Machado-Lim, and I will be lecturing on glomerulonephritis in children, and it is entitled, Why is My Pee Brown? So this is my objectives: to present the definition and etiology of hematuria, to discuss the etiology, presentation, diagnostics, and management of glomerulonephritis in general, to give an overview of clinical parameters of common etiologies of glomerulonephritis, and to give just a quick review on post-streptococcal glomerulonephritis. And I have nothing to disclose. So before I start, I'd like to pose a question on everyone. What color is your urine? So I have on your screen numbers corresponding to different colors of urine. So you may type in the chat box the colors of your urine previously or prior to logging into Zoom, so that I can tell you what your urine says about you. Okay, let me see. Okay. Some says 2, some says 3. All right. Okay, that's relatively good. So here is the interpretation of your urine. So if you answered 1, that's overhydrated. So sobrang dami nyo siguro ininom na tubig na parang kulay tubig na rin siya. Okay, 2 is good, 3 is fair, 4 is lightly dehydrated, 5 is dehydrated, 6 is very dehydrated, and 7 is severely dehydrated. Siguro wala naman po masyadong nagsagot ng 6 and 7 kasi these are the colors of concern. So medyo iba na yung kulay niyan. So the question is this only dehydration? So what if it's not? So, and still the color or the urine color is still dark brown or probably tea colored, then we'd probably think of hematuria. So hematuria is simply defined as red blood cells in your urine. And it can be gross or microscopic. So when you say gross hematuria, you can see it by the naked eye. And when you say it's microscopic, The RBCs are more than or equal to 5 per HbF in your urinalysis. Okay, what is the etiology of hematuria? It can be glomerular and non-glomerular. So when we say glomerular, it pertains to your kidney. If it's non-glomerular, it is outside of the kidney, or the structures outside of the kidney. Okay, so for the non-glomerular etiology, you have your UTI, you have your renal calculi are your stones, trauma, or exercise-induced malignancies pertaining to nephroblastoma, renal cell carcinoma, rhabdomyosarcoma of the bladder. Also, your drugs like rifampicin and chloroquine, dyes, metabolites, food like beetroot and blackberries, and urates in infants. So urates are very common. We see that in your clinics in newborns and infants. Okay, so for the glomerular part, etiology is a familial hematuria syndromes that are thin basement membrane and Alport syndrome. You have your glomerulonephritis. Under that is your post-infection, your rapidly progressive GN, IgA nephropathy, Henoch-Lim nephritis, and lupus nephritis, and your hemolytic uremic syndrome and renal vein thrombosis. For the purpose of this lecture, we will just focus on glomerulonephritis. Okay, so the definition of glomerulonephritis is simply inflammation of the kidneys. So this is your normal kidney, and this is an inflamed kidney. So what is it? What is the pathogenesis of glomerulonephritis? So we have two mechanisms here. You can see here the deposition of circulated immune complex and the in situ binding of antibodies with or without immune complex formation. So we start with the immune complex. So just a review, this Y-shaped thing here is your antibody and the circular red one is your antigen. So immune complexes should be cleared in the body, but in some cases wherein it's too big or it's too many, they get filtered through and they end up in these tight spaces over here. So it's either they deposit here at the outer surface of your glomerular basement membrane, or even if they get through, they would end up here in the inner surface of the glomerular basement membrane, or perhaps in the mesangial area. So when they end up there, or they deposit there, they attract inflammatory cells and they activate the complement system. Therefore, glomerular injury takes place. Now, the other mechanism is your in situ binding of antibodies with or without immune complex formation. So there are antibodies specific for an antigen found inside the kidney. So it's either here in your podocytes or here on your basement membrane antibody. And when they bind there, they cause attraction of leukocytes and they activate again the complement system, causing glomerular injury. Okay, for the etiology of glomerulonephritis, we do have your acute glomerulonephritis, and that is your acute post-infectious GN. So under that, we have your post-strep and your glomerulonephritis of infective endocarditis and shunt nephritis. But we will just deal on with post-streptococcal GN. Also, we have your acute glomerulonephritis associated with systemic disease. So we will deal also with SLE and Henoch-Lim purpura. There are a lot more, but we won't tackle about that anymore. And for your chronic glomerulonephritis, we also have your focal segmental glomerulosclerosis, membranoproliferative, membranous GN, and your IgA nephropathy. So this we will tackle a little bit later. Okay, so most typically, the child with acute GN will be seen because of the sudden development of change in urine color. So hematuria in children with HEN is typically described as coke, tea-colored, or smoky-colored urine. So it is a result of glomerular injury and inflammatory rupture of your glomerular capillaries with the resulting bleeding into the Bowman space. So as you can see on this slide, you have a normal glomerulus on the left side. So it keeps most of your proteins and RBCs inside. Now, a diseased glomerulus has breaks or a rupture in your capillary, causing these RBCs to spill in the urine. So AGN can usually be recognized by the clinical picture of hematuria, fluid overload, that is your edema and hypertension, and some evidence of renal insufficiency like oliguria and azotemia. So azotemia may be present or not, and this is the elevation of your BUN and creatinine. So this comprises your acute nephritic syndrome. Okay, so we now have to investigate the history, and it is imperative to obtain a thorough history focusing on the identification of some underlying cause, such as recent infection or systemic disease, like your preceding streptococcal infection prior to onset of symptoms. So if it's a pharyngitis, it's 7 to 14 days. If it's a skin involvement like pyoderma, it's 3 to 6 weeks. So if you elicit this information, probably you are going to look at post-streptococcal glomerulonephritis. Now, you also have to ask if there is recurrent macroscopic hematuria 2 to 3 days after the onset of an upper respiratory tract infection, because this might pertain also to IgA nephropathy. Since AGN may be the presenting complaint of a multi-system illness, a complete review of systems is vital. So fever, abdominal pain, purpura, probably you'd look for inoculant purpura. And when you see rashes, mouth ulcers, joint pains, you also think of SLE nephritis. Obviously, a good urinalysis is the first order of business in assessing a child with suspected AGN. So the presence of RBC or red blood cell cast is diagnostic of glomerulonephritis. If you have also granular cast, that would pertain to a glomerular origin. Now also our RBC morphology would be helpful, but it would depend on your laboratories, depending on the cutoff. But in books, it would say more than 30% of this morphic morphology, it would pertain to a glomerular origin. Okay, how about your CBC? AGN is AGN. When in AGN, you can see also a mild degree of anemia and is frequently seen, and it is more likely delusional. More significant anemia would be evidence that the process may be more chronic. Okay, now your WBC and platelet count are usually normal. There's no important changes in the white blood cell count or platelet count in most cases of AGN. A normal platelet is purpura and petechiae is a usual finding in HSV. So you might wanna look at that. Okay, so for assessing renal function, we have your creatinine and BUN and electrolytes. Two streptococcal antibodies that are commonly employed in this diagnosis is your anti-streptolysine O and your anti-DNase B antibody. However, anti-DNase B antibody is not really requested in our setting. Okay, we also have serum albumin because a slight degree of hypoalbuminemia is typical in many inflammatory processes. Okay, and by far, the most important test also to obtain is your complement system, your C3 and C4, because in post-streptococcal glomerulonephritis, C3 is very low, sometimes with minimal decrease in C4. For imaging, you can order a chest X-ray, and it helps to see for evidence of pulmonary edema or hemorrhage. ECG for evidence of hyperkalemia, and an ultrasound, a renal ultrasound, which helps in assessing the size and echogenicity of your kidneys. Okay, for physical examination, we can check the vital signs, particularly the blood pressure, because the blood pressure that is more than or equal to the 95th percentile plus 12 millimeter mercury for the child's age, sex, and height is already worrisome. Tachycardia and tachypnea point towards symptomatic fluid overload. Cervical lymphadenopathy may be a residua of a recent streptococcal pharyngitis. Significant abdominal pain may accompany HSP. So the rash of HSP is, while characteristic when florid, it may initially be subtle and limited to the buttocks or the doors of the feet. Now, joint involvement occurs in some multisystem disorders with HEN. So small joints is more typical of SLE, while knee involvement is seen with HSP. Also, you have to look for evidence of fluid retention. So facial edema, pedal edema, ascites are evidences of fluid retention. Scrotal edema and orchitis is an occasional finding as well in HSP. Also, evidence of circulatory congestion like cardiomegaly, pulmonary edema, and tender hepatomegaly. So for the complications, we have hypertensive encephalopathy, congestive heart failure with pulmonary edema, acute kidney injury accompanied by nephrotic feature of anosarc. So the medical management, or the cornerstone of medical management in glomerulonephritis, is your removal of excess fluid and sodium. So for more details regarding that fluid volume restriction, you can compute it with your insensible water loss. That's 400 to 500 per BSA, or 20 to 30 ml per kilo per day, plus your previous 24-hour urine. You divide it into two if they are in diuretics. So a low salt diet, less than 1 millimole per kilo per day, for 2 grams in adults. A low potassium diet of 0 to 150 milligrams per serving, or less than 3.8 millimoles per serving. A daily monitoring of weight, strict input and output chart, and close blood pressure monitor. So if you'd ask me how close is close blood pressure monitoring, it would depend on the situation. So if this is an ICU patient, of course, it's every hour. But if hindi naman sobrang taas ng BP, or hindi naman siya hypertensive urgency or emergency, maybe you can monitor like Q4 or probably Q2. Okay, we decrease fluid and sodium overload to prevent hypertensive encephalopathy. So we can use your loop diuretics at a dose of 2 to 5 milligram per kilo per dose. Medyo mataas ang dose ng furosemide na to. So intravenous administration if patient has severe fluid overload and or is hypertensive. So the treatment of hypertension, we can use your antihypertensive medications, should be started if the BP is still elevated after giving IV furosemide. So for hypertensive emergencies, when you say hypertensive emergencies, meron na yan seizure, meron na yan changes in sensorium, we can use nifedipine or your intravenous glyceryl nitrate or labetalol infusion. However, the glyceryl nitrate and labetalol infusion are not commonly used in our setting. So I just had to put there, maybe you can use intravenous nicardipine at this dose. So you can also use your your long-acting antihypertensive if BP is still persistently elevated, like your calcium channel blockers, so amlodipine at this dose. Okay, we have to be cautious in using your ACE or ARB if there is hyperkalemia and decreasing renal function. So in hyperkalemia, you avoid high potassium containing foods, so like milk, tomatoes, fruits, and fruit juices. You use your IV furosemide. If serum potassium remains at 6 to 7 millimoles per liter, despite 2 doses of furosemide, you may give oral risonium at 0.5 to 1 gram per kilo per organ. Max is 30 grams. That's your polystyrene sulfonate resins. In our setting, we have kalinate and resin valve. So if your serum potassium is more than or equal to 7 millimoles per liter and you have ECG changes, then you can give your IV 10% calcium gluconate, your nebulized salbutamol, glucose and insulin drip. You also have to be cautious in using sodium bicarbonate because of the risk of increased hypertension from sodium load. So if dialysis, if with severe oliguria, not responding to furosemide with the following criteria. So if you have severe hyperkalemia, severe acidosis, uncontrolled hypertension, and severe fluid overload and pulmonary edema, then dialysis should be done. So here are some clinical features of acute glomerulonephritis associated with these diseases. These are the common that we see, like your post-strep. So the clinical parameter of preceding upper respiratory tract infection in post-strep, 10 to 14 days before the onset of gross hematuria. And then your pyoderma may be up to 6 weeks. So the duration of a hematuria in post-streptococcal GN is 7 to 14 days. Microhematuria can persist up to 1 year. In HSP nephritis, they also have a preceding streptococcal infection, and duration of hematuria, gross hematuria occurs in minority of patients. Microhematuria is more common, and it usually resolves in few weeks. IgA nephropathy, on the other hand, 24 to 72 hours before onset of hematuria, and is often viral in nature. So the duration of hematuria is 2 to 14 days, just like your post-strep. However, I'd like to highlight that this is recurrent. So recurrent gross hematuria with URI, it is more likely IgA nephropathy. So microhematuria can persist but may disappear in between gross hematuria. Okay, for the complement C3, it's low in post-strep, it's normal in HSP and IgA. Other clinical associations with post-strep is your hypertension, hyperkalemia, oliguria, and mild azotemia. For HSP nephritis, the rash, joint pains, abdominal pain, and sometimes it has a risk for intussusception. While in IgA nephropathy, you have your acute kidney injury, and some have nephrotic syndrome. Okay, this is just nice to know. Renal biopsy finding for your post-strep would have your humps, that's the subepithelial electron dense deposits, while HSP and IgA, they have the same findings in renal biopsy. So they have mesangial cell and matrix proliferation, mesangial IgA, IgG, C3 complement deposits. Okay, for the prognosis for post-strep, it's excellent. At HSP nephritis, it's mostly also excellent because most patients recover. There is only a risk of CKD for those with severe renal pathology. However, IgA has a long-term risk of CKD and hypertension. So you might want to watch out for that IgA nephropathy. Okay, just some notes on lupus nephritis. 60% of lupus patients will develop clinically relevant nephritis. And most SLE patients develop nephritis early in their course. Children are more likely to develop severe nephritis than elderly patients. Microscopic hematuria was found to occur in about 80% of patients during the disease course. So some with associated proteinuria. So macroscopic hematuria is rare in lupus nephritis. Okay, just to give a review on post-streptococcal glomerulonephritis. Again, it is the most common form of glomerulonephritis encountered in children. It is encountered between the age of 2 to 15 years old. Occurrence below the age of 2 is rare. Again, it follows an upper respiratory skin infection with group A, B hemolytic streptococcus, pharyngitis 1 to 2 weeks, pyoderma 3 to 6 weeks. Aside from your streptococcal variants, other post-infectious causes are your bacteria, viruses, fungi, and parasites. So clinical features of your post-streptococcal glomerulonephritis is your acute nephrotic syndrome. So you have your gross hematuria, oliguria, hypertension, edema, and impairment in renal function. So this is an interesting slide, and I just had to put it because this is a graph of the time course of clinical and laboratory manifestations seen in post-streptococcal glomerulonephritis. So just to name a few, gross hematuria would last approximately at 3 weeks, edema for 2 weeks, hypertension 7 to 10 days, mostly 3 weeks, proteinuria 5 weeks to almost 3 to 6 months in some journals. Hypocomplementemia, or your C3, would last for about 6 to 8 weeks. So for the diagnostics, the ASO titers, your anti-DNA-CD antibody, your ASO titer may not be significantly elevated in some patients early in the course of the disease and should be repeated to demonstrate a rising titer. So some ASO titers may remain low in patients with impetigo-associated post-strep GN. A decrease also in your serum complement 3 resulting from its consumption in post-strep GN is seen in the majority of patients early in the disease, and the decrease is profound in some patients. So complement C4 is usually normal, but low levels have been noted in a minority of patients. So again, we also have to get your creatinine and BUN and electrolytes as well, because hyperkalemia is a common in most patients and can be severe in some. So again, fluid restriction, sodium and potassium restriction, treatment of fluid overload with diuretics, and treatment of hypertension is the core treatment of post-streptococcal glomerulonephritis. Now, is there a need for antibiotic therapy? An evidence of concurrent infection or protracted course of nephritic signs at time of diagnosis, then you still need your antibiotic therapy, because a common sense would say it's post-strep, it's post-infectious, it's technically already there's nothing to treat anymore. But here you still give your antibiotic therapy because sometimes there is evidence of still concurrent infection in a protracted course of nephritic signs. So you can give your benzathine penicillin at 1.2 million units for adolescents and 600,000 units for children every 6 hours, and your erythromycin 250 milligrams for adolescents and 40 milligram per kilo in children every 6 hours per RM for 5 days. Also, if infection is not apparent, antibiotics are given just to prevent cross-infection of household members. So prognosis of post-strep GN resolves in 90% of cases, and long-term prognosis of PSGN in children is excellent. Okay, what are indications for renal biopsy? Because some of our patients might ask, kailangan po ba i-biopsy ang anak ko? So in post-strep GN, you don't really do a biopsy for the reason being that it's really self-limited. However, there are indications for your renal biopsy. So severe anuria or rapidly progressive course, meaning ang taas agad ng creatinine, ang taas agad ng BUN, and hindi umiihi yung patient. Hypertension of more than 3 weeks, depressed GFR more than 2 weeks, evidence of systemic disease. Like for example, if you're looking at SLE, you have to also advise a biopsy. Hypocomplementemia more than 8 weeks, persistent proteinuria at 100 milligram per millimole persisting more than 6 months, and persistent microscopic hematuria more than 18 months. So I guess that's my last slide. These are my references. So these are my references, and thank you for listening.
Thank you, Dr. Marie Michele, for your comprehensive but easy to follow discussion with hematuria and acute glomerulonephritis. Let us now proceed with the question and answer. May I ask the audience to write their questions in the chat box. So far, wala pang questions, Doktora. Can I can I ask na lang po, ako na lang, Doktora,
Yes.
for post-treatment monitoring, what do you suggest? Do we monitor the patients with urinalysis every month? For how long? And what other tests do we need?
Yes, you can monitor the patient. Actually, it is advisable to monitor the patient, especially you have to get a urinalysis because your urinalysis tells you a lot of the disease. So sometimes in the course or in the duration of the course, kasi post-trip, makikita mo pa kasi yung hematuria until 6 months, until 1 year. But in the event na makita mo there is already increasing proteinuria, like nephrotic range. So I think you have to investigate again. So that's why it's important to monitor these patients. You can do it monthly for the next 6 months, and then if it's okay naman, yung okay naman your analysis, then you can adjust. Because I also have patients na okay naman sa una, but then boom, they come to me, rapidly progressive na pala. So parang ang next step na baka dialysis na kami. So parang in between, nag-iba yung course, pwede kasi yun. So it is very important to monitor your patients. Yan po.
Thank you, Doctor. Ayan, we have questions na po, Doctora, in our chat box. Sa question ni Dr. Chumacera, the indications for renal biopsy was discussed earlier by Doctora. And the question of Dr. Reden Alfonso Silva, in the absence of nifedipine, is it safe to give clonidine to control the hypertensive episodes?
Yes, Doc. Pwede naman po yung clonidine, no? Kaya lang siguro, since clonidine is set, you have to also monitor the drop in the BP. Because hindi naman po natin gusto na sobrang bilis na pagbaba. But yes, in the absence of nifedipine, kasi there was a time ata na walang nifedipine, parang nag-phase out yung nifedipine for some reason. But yes, we can give clonidine if we don't have anything.
Our next question from Dr. DCP. The use of antibiotic in post-strep glomerulonephritis. This was also discussed by Dr. earlier. So do we have...
Okay, Dr. po, opo, use of antibiotic in post-strep GN, yes, we still give it for the reason po na we are preventing the transmission for other household members. And yun nga po, no, kung protracted course, ibig sabihin, actively, meron pa rin talagang nephritic signs, yes, we can still give.
Are there any more questions? Please, write na in the chat box. Okay na, Doktora. There's wala na pong questions na